Hello, everyone. Welcome to 2016 and the first in our winter series of geriatric healthcare lectures. My name is Barbara Cochran. I'm director of the DeTournier Center for Healthy Aging here in the School of Nursing. I'm also associate director for the new Northwest Geriatric Workforce Enhancement Center. This is a new center, but the same good old folks from the Northwest Geriatric Education Center, and so hopefully it will all look familiar and comforting. We will be doing a lecture series, 10 lectures this term, and another 10 lectures focused on Alzheimer's disease and related dementias in the spring term. So I hope you'll stay with us and stay tuned in. You should have gotten information from your site coordinators about continuing education contact hours. We do need a profile so that we can report on numbers and various other kinds of information, no identifiers, to our funding agency so that we can continue to offer this series. The Health Resources and Services Administration, HRSA, has been very generous in funding our activities, and we were very pleased to be one of the geriatric workforce enhancement centers funded during this last go-around. So I think that's, trying to think if I've forgotten anything else. Welcome to Alaska, Wyoming, Montana, Idaho, Washington, and anyone else, the VA here in Seattle, and anyone else who might be participating. Here in Seattle, we have in this room community professionals from the area, health sciences students, as well as faculty and other staff participating. And today I'm very pleased to introduce Lingtak-Neander Chan, who is a associate professor of pharmacy and interdisciplinary faculty in nutritional sciences at the University of Washington. His primary research focuses on the absorption kinetics of micronutrients and drugs after bariatric surgery and other GI tract repairs. His areas of interest include the medical and nutritional management of critically ill patients and patients who are at risk for nutritional deficiency, specifically patients who are critically ill, elderly, obese, or have undergone extensive GI tract surgery. So he brings a lot of expertise to this topic. He's also interim chair of the Department of Pharmacy, and he's going to be talking with us today about monitoring vitamins and supplements in geriatric patients. Welcome.
Thank you, Barbara. Thank you for the invitation. It's my pleasure to give you an overview of this, to me personally, very interesting topic. The learning objectives are listed, and there are 3 primary goals I want to accomplish and give you an understanding of how vitamins and supplements are regulated in the United States. And it has a direct effect on how we understand clinical assessment and taking supplementation. Then we'll talk about symptoms and laboratory management, laboratory monitoring of vitamin deficiencies, and with a focus specifically on vitamin D, thiamine, iron, and to wrap things up with omega-3 fatty acids. And I'll give you some data why I choose these 4 areas. Now, just a brief history, and to get things started, we have some live audience here. See if you can come up with the answer. Terms comes from blank, and also deficiency diseases as named by a Polish biochemist back in 1912. What's that blank? If you break down the word vitamin, it stands for vital amine. So it was thought to be a class of amino acids that provides vital physiological functions. Now, it was later found to be not true. They are vital, but the majority of the compounds are not amino acids. The Egyptians recorded the symptoms of blank as early as 1550 BC. And then, several thousand years later, a British naval surgeon discovered that oranges and lemons can actually improve these symptoms for sailors. Scurvy, very good, which is associated with vitamin C deficiency. Industrial Revolution was associated with an increase in blank, especially in children. Pardon me? Asthma? Nope. Rickets, very good. With industrial revolution, more and more people started working indoors in the factory. Overall activities goes down. So exposure to sunlight goes down, endogenous production of vitamin D goes down, and more newborn presents with rickets. And finally, another historical question, the anti-beriberi factor was described by this chemist. And this anti-beriberi factor was eventually named thiamine, or vitamin B1. So it gives you a brief overview of what we understand about vitamins. And there has been description of the symptoms for many, many years, but the research doesn't really start until early 1900. Okay, now let's start with regulations. It is important to bring you up to date on the regulation. The Dietary Supplements Health and Education Act, also known as DSHEA of 1994, formed the current regulation for dietary supplements, which includes vitamins. Now, what is it about? It was signed in 1994 by then President Bill Clinton. And the idea is to meet the needs of consumers and manufacturers. So the goal is to meet both two groups, the consumers who want to have supplements easily accessible, and the manufacturers who can make money. The Congress also felt that there is a positive relationship between supplements and dietary practice and good health, and maybe a way to reduce healthcare costs. And you may remember the platform for President Clinton back in the early 90s involved healthcare reform. So cost was one major issue. And the hypothesis is, well, by providing easier access to vitamins, supplements that is part of the diet, it may actually promote good health and reduce healthcare costs. Unfortunately, this was never proven. What is the definition of dietary supplement under DSHEA? And it includes any of the ingredients other than tobacco. That's a good thing, right? A vitamin, a mineral, which include calcium, magnesium, any sort of mineral that we take, herbs, and botanicals. So that opens a whole new set of door for herbal supplements, amino acids, and many other things used to supplement diet. So that's the intention. How can you sell them? It is intended for ingestion in pill, capsule, tablet, or liquid form. So what that means is you can make a vitamin C tablet under DSHEA. But if I make a vitamin C injection or a vitamin C ointment, I have to go through the Federal Food Cosmetic Act and go through clinical trials. What DSHEA offers is that it would bypass the lengthy clinical trials to prove efficacy and safety, because the assumption is all the ingredients are part of our normal diet. So literally, what you and I can do is that we can start our own startup tonight in my basement and start marketing. And the law would not prohibit us from marketing our own brand of vitamins or supplements, as long as we follow good practice, and that's an assumption. And that brings up a lot of concern about the purity, the quality, or even contamination. And in fact, it's been pretty widely reported in the literature that product consistency is lacking in many dietary supplements. And also there are studies suggesting that some products do not follow good manufacturing practice and bring in contaminants ranging from arsenic to other unwanted materials. So it's really a concern sometimes from the safety and efficacy perspective. Another thing to keep in mind that these are meant to be called dietary supplement, and they cannot make any claim to diagnose, prevent, mitigate, treat, or cure specific diseases. Right, so now we have a pretty basic understanding of DSHEA and what it covers and what it allows. Let's talk about vitamins and micronutrients. Now, micronutrients refer to compounds that we need in trace amount on a daily basis, but lacking them, we may develop deficiency. So that may include many vitamins as well as trace elements. Several studies have shown that the use of micronutrients is pretty widespread worldwide. The study from Washington State by now is over 15 years old, but still, it's shown that over 75% of the study cohort use at least one supplement daily. And the use of supplement is especially common amongst cancer survivors. This slide wants to show you one important message. Supplements are not completely safe. This paper was published in the New England Journal of Medicine just a few weeks ago, looking at the frequency of emergency department visits associated with dietary supplement use. And you can see that on the y-axis, that's the number of ED visits. And on the x-axis is patients divided by age groups. Now, you can see that regardless of the age group, dietary supplements is associated with more than 2,000 visits to the ED per year. And the causes varies depending on the age group. Now, you can see that for folks who are in the 20s to the 50s, the most common cause is weight loss products, shown by purple bar. And as we grow older, weight loss product is not as commonly used by the elderly, but instead, you see an increase in the green bar. The green bar and the dark green bar refers to calcium and iron. Now, the number looks pretty small, but if you look at the relative percentage in that age group, that's about 20%. So about 20% of ED visits was reported to be related to calcium or iron or other nutritional supplements. It's pretty significant. Now, why? We don't know, but many of them include GI symptoms, which is well-known side effect of iron supplements. There are also cases of acute intoxication. But the bottom line is dietary supplements are not completely safe. We have to keep that in mind. Now, this slide gives you a very quick overview of the major vitamins for human health, as well as the common symptoms. And you can probably extract the information from most biochemistry textbook or clinical medicine textbook. I won't go through it in detail. This is mostly for your information. Many of them are pretty standard. You may recall vitamin A deficiency is associated with night blindness. And niacin deficiency is associated with pellagra, with a rash all over the body. Some of the symptoms that we don't think we will see in Western society, but we start seeing again, mostly due to the more widespread use of bariatric surgery and gut resection. In addition to symptoms, what else do we use to assess vitamin status? Think about it. By the time a patient presents with beriberi or a night blindness, that's not a good sign, right? That's too late. What we would like to do is to prevent that from happening. And many of the assessment can be done before symptom occurs. Most important thing is diet history, followed by more diet history. So I cannot emphasize the importance of going through a thorough diet history, regardless of your professional status or your specialty. Somebody who has not been eating well for 2 weeks is at very high risk of developing thiamine deficiency. Somebody who never go outside, who doesn't have dairy in part of their diet, has very high risk in developing vitamin D deficiency. So by monitoring a patient's intake and pattern, it gives you a very good idea of what to watch for, and it also opens up the door for specific laboratory tests if necessary. The GI tract anatomy plays a role. I've already mentioned to you that bariatric surgery or other intestinal repair may reduce the capacity to absorb micronutrients. The lifestyle makes a difference. As I mentioned, you go out in the sun versus you hide indoor. That changes the dynamics. So nursing home residents who are not mobile, staying in the room most of the time, has much higher risk for developing vitamin D deficiency versus a 90-year-old who still go outside and take walk and hikes. There are laboratory tests available, and some of them are simple blood tests based on plasma concentration. Vitamin D is one example. There are other tests that doesn't directly measure the blood concentration. Rather, it measures the functional status associated with the vitamins. And the classic example is erythrocyte transketolase activities, or ETKA for thiamine. Now, the reason for some nutrients we measure the functional status is that the blood concentration doesn't tell us a whole lot, because certain vitamins are mostly stored inside the cells. So when you measure the blood, it's always low. And that's why we would use a functional test instead of a plasma test, such as vitamin D, where we can actually provide a better predictive response based on the blood vitamin D value. So again, to sum up, there are 3 ways we can look at and assess a person's vitamin D status, starting with history, the type of diet, the food, the activity. That give us an idea whether the patient is at risk. Then there are very, very specific physical symptoms we can look for to confirm the presence of deficiency. Then there are blood tests we can use to assess a specific nutrient status. But there are a few things to keep in mind. The clinical data are often underreported in this area due to publication bias. Very rarely people write a paper documenting, well, we don't have vitamin D deficiency in this population. And usually that paper, if submitted, is not being published. So there is a strong publication bias towards we want to find something. So the exact incidence of certain nutrient deficiency is really not clear, which make it more challenging for us to predict, well, in this patient, what's the likelihood of having thiamine deficiency? In this patient, what's the likelihood of having vitamin E deficiency? So that's why we always have to go back to the individual's history and clinical presentation. Another thing that is related to DSHEA, we cannot guarantee the product quality of the supplements. So some people can tell you, well, if I've been taking vitamins or this kind of supplements for years, it doesn't mean they're really getting optimal amount, so they can still develop deficiency. And that's perhaps one of the most challenging aspects of clinical management. And that's when blood test becomes more valuable. The next 2 bullets has to do with assay. We don't have a standardized methods to measure these compounds in many cases. So their interpretation is subject to institutional variance. And finally, depending on when the blood samples are drawn, sometimes that makes a difference. For example, it is extremely rare to have low folic acid level. The reason is most of our food is fortified with folate. And when you measure folate concentration after the meal, everybody would have normal folate concentration. So if you were to really test for folate concentration in an individual, it should be fasting. Now, a lot of times that's not done correctly, and that would affect your interpretation. So good clinical judgment is important to ensure accurate interpretation of the results. Now let's start with what's being recommended for general intake, especially in older adults. This is the Institute of Medicine report summarizing the recommended daily intake of various micronutrients. And this is for 7 years old and older. Vitamin D, I changed it to red because if you look down below, for adults that are less than 70 years old, the recommended intake is 600 units. So for all adults, 600 units per day, but if you are 70 years or older, 800 units a day. And that's minimal. And I think in our region, we consider this is probably not adequate. We'll talk more about it on our discussion with vitamin D. So with all these vitamins, all these micronutrients, where do we start? I think one of the best ways to start is to look at our published evidence in spite of some selection biases. Now, here is a meta-analysis conducted by a Dutch group. They look at nutritional studies published in the last 50 years. And they assess the cohort based on their reported dietary intake and determine which vitamin is more likely to be deficient in these older adults who are 65 and older. And you can see very, very clearly that vitamin D jumps out. Now, these are studies that include subjects living in North America, Europe, Australia, and New Zealand, mostly Western Europe, Western world. 85 to 90% of older adults do not meet the recommended vitamin D intake, followed by thiamine, which is number 2 on the x-axis. So that's what I will focus the discussion on in the next half hour or so. Let's start with vitamin D. Vitamin D is both a hormone and a vitamin. Everybody knows what hormone is. It is part of the endocrine system that regulates physiological function. Vitamin refers to compound that you need to extract from diet. We don't make enough. Now, you may recall, we do make vitamin D. That's why we go out in the sun. And as illustrated by this cartoon, when we go out to the sun, UV light activates pre-vitamin D. The problem is you can get yourself burned in the sun. We will not make enough endogenous vitamin D without diet intake. And that's why vitamin D is both a hormone and a vitamin. One thing I want to emphasize is the UV spectrum that stimulates vitamin D synthesis is UVB. And most tanning booths emit UVA. So we can't recommend somebody who is deficient in vitamin D to just go to a regular tanning booth because 90 to 97% of the UV spectrum is UVA, which is not adequate to activate vitamin D, but enough to increase the risk of skin cancer. There are FDA-approved UVB lamp available. So if that's the intervention we have to go, we have to follow UVB lamp. In terms of diet, there's a lot of food that contains vitamin D, but of course we are well aware of dairy products, milk, eggs, fish, are pretty rich in vitamin D. Now, vitamin D exists in a pre-active form and then is activated by the liver to form 25-hydroxy vitamin D, also called calcidiol. And this is basically the storage form of vitamin D. It stays in the body. 25-hydroxy vitamin D is also the form that we check through blood test. It is further metabolized to 1,25-dihydroxyvitamin D or calcitriol. So calcitriol is the most active form of vitamin D, but we don't routinely check that in the blood. There's a reason for that. Number one, calcitriol has a very short half-life. We are talking about 3 to 4 hours. So our morning calcitriol concentration would be different from the evening calcitriol concentration. So it's not really an accurate assessment of the body status. Calcidiol, the one that under the liver, on the other hand, has a half-life of about 15 to 20 days. So it fully reflects how much vitamin D storage we have. And that's why, at least at the present time, we check 25-hydroxyvitamin D for vitamin D status. The function of vitamin D, there's no need to expand too much. Of course, it helps maintain calcium homeostasis, which can help prevent osteoporosis. It has also a number of other functions, including immune function regulation and regulating tumor growth. But the most established function is certainly calcium regulation and bone health. How common is vitamin D deficiency in this country? This is based on the national data from Ann Haynes. And let's define the term. Deficiency is based on 25-hydroxyvitamin D being less than 20 nanogram per milliliter. And insufficiency is between 20 and 30. So if you look at the mean vitamin D is 19.9 or 20, which means about half the population in this country is deficient by definition. So this is a very widespread micronutrient deficiency, which is very consistent with the meta-analysis result I just showed you from the Dutch group. If you look at men and women, the average vitamin D concentration is comparable. So there's no significant gender-based bias. What are the predictors of vitamin D deficiency? Skin color appears to have a predictive value. African American in general is 9 to 10 times higher in terms of having risk for low vitamin D. When you compare Hispanics versus Caucasian, that changed to about 3 to 3.5 times. And fewer studies were published in Asian, but the belief is between 3 to 3.5 as well. Why? We are not completely sure. There are several explanations behind that. One thing we know for sure is if you sample 100 African American and 100 Caucasian subjects, you will get a much lower average vitamin D concentration for the African American cohort for sure. But recent science has suggested that African Americans have a different binding capacity between the serum protein and vitamin D. Now what that means is even though their plasma concentration may be lower, they're more likely to release vitamin D to where the tissue would need it. So it may offset the changes in the overall number. But we haven't really looked into the clinical outcomes. So that remains an area for debate. But that really brings up something called the vitamin D paradox, is that if you look at epidemiology, in spite of being higher risk of having low vitamin D, African American also historically have lower risk of fracture. So that really suggests that there's much more for us to explain and learn in the vitamin D biology. But for general practice purpose, we still anchor different ethnic group or race background to the same vitamin D reference concentration for now. And that's one thing we have to kind of accept until we can learn and understand more about it. Other predictors on the slide, lack of college education or poor health status, the explanation is probably dietary intake. Imbalanced diet may be confounded by socioeconomic status. Obesity is highly associated with vitamin D deficiency, which I'll show you in another slide later. And then the last two, they are pretty much self-explanatory. Low HDL probably reflects an imbalanced diet, and a diet lacking in vitamin D, rich in vitamin D. And then not taking milk products daily. Here's our own research data led by one of my graduate students. So shown on the y-axis is vitamin D concentration in the plasma, and we use 30 as our cutoff for deficiency. And on the x-axis, it is body mass index. And these are all obese patients. So as you can see that more obese patients tend to have much lower vitamin D concentration. You can see that as you increase your BMI from 30 to 70, the percent of patients with vitamin D deficiency goes way up. And that's very consistent in all research in obesity. So it is well known that obese individuals are more likely to be a vitamin D deficiency. Explanation: one explanation is sequestration of vitamin D to the fatty tissues, which results in much lower functional vitamin D in the blood. Now, what do you see on this slide? Again, shown on the y-axis is vitamin D concentration in the blood. On the x-axis is seasons. Now, you will see two things. Number one, the meat eaters consistently have higher vitamin D concentration in all seasons than vegetarians. Vegans have the lowest vitamin D concentration. And that's consistent with what we understand about diet, right? Dairy products, eggs, fish, and meat contain richer sources of vitamin D. But another thing you see here is a seasonal variation. In summertime, regardless of your diet, your vitamin D level is higher than wintertime. Now, if you live in LA or Phoenix, it may not make that big a difference. But if you are in the northern latitude, it may make a big difference. So these are studies conducted in Boston, which is 42 degrees north. And you can see that the endogenous vitamin D formation between July is way, 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 way higher than what you can form in October in the winter season. And you may ask, so what's the big deal? That translates to some very interesting clinical observation in this Boston study. On the left side is the fall frequency over time. You see the peaks and troughs and peaks and troughs, but you see the highest peak fracture rate towards the end of the year and the beginning of the year, winter season. So the pattern is highly replicable. Now, of course, if you're a skeptic, the study was conducted in Boston. What is Boston known for? Snow and ice. So of course you fall. And so there are data on the right-hand side to confirm it. On the right-hand side, it showed the change in bone mineral density. And you can clearly see that in the fall and winter time, the loss in bone mineral density is much more substantial than during spring and winter time. And that coincides with the change in vitamin D concentration. There is an average of a 13% reduction in blood vitamin D concentration in wintertime, versus in summertime, there is a net gain for over 20%. So the take-home message, seasonal variation for vitamin D is very profound, especially for individuals living in the northern climates. Diet plays a role, and then activities and genetic appears to make a difference as well. So now, what is our risk living in the Pacific Northwest? Now, I'm in Seattle, so I use Seattle as the example. You may not realize that we are further north than Boston. We are 47.6. We are further north than Fargo, North Dakota. We are further north than Green Bay, Wisconsin, or even Quebec City. So we are one of the most far north city in this country. So when you look at vitamin D endogenous exposure to sunshine, that explains why we are especially at risk for developing vitamin D deficiency. Now the good news is when you look at our population as a whole, we tend to have high activities and healthier diet. So that may offset some of the risk. There's no comprehensive studies looking at the incidence of vitamin D deficiency in Pacific Northwest, especially in Washington State. One of my grad students looked at obese patients in Seattle area, and we found an incidence of 63% vitamin D deficiency, which is high, but is actually lower than what we have expected. So, okay, so we know there is a risk of vitamin D deficiency due to diet, due to latitude, due to sun exposure, due to activities. But bringing up the vitamin D level, does it do any good? Shown here is the correlation between vitamin D intake and fall risk. You see a very clear reduction in fall risk with increased vitamin D intake. And that parallels the change in vitamin D concentration in the blood. The higher the blood concentration, the vitamin D you have, the lower fall risk you may actually experience. So there seems to be pretty strong data in the last 15, 20 years suggesting the benefit between vitamin D supplementation or optimal vitamin D intake and the reduction of fall risk, which can lead to bone fracture. So now, how do we give vitamin D? And there is a simple rule. So for every 1,000 units per day, it can increase your blood concentration by about 10 nanograms over a period of 3 to 4 months. So let's say if my vitamin D level is 20, the goal is to bring it up to 30. What I can do is I can take an additional 1,000 units a day for the next 3 to 4 months. And most likely, 4 months from now, my blood vitamin D level should be approaching 30. Now, do keep in mind that the simple rule applies to younger, more healthy individuals who are not overweight or obese. So if you have an obese individual, you're more likely to need a higher doses to achieve that role. And if you have other risk of utilizing more vitamin D, the amount may need to be increased. If you're into equation, here is a very, very specific equation derived by the Dutch group, and it gives you an estimate of the total vitamin D deficiency. So if you want to know the total amounts to be supplemented, you can use this approach, and then you can simply divide the dose into several regimens. And the recommended intake is no more than 25,000 units per week. So some people may have to take it for 6 weeks, some people may need 8 weeks or 12 weeks, depending on the total deficiency. Both methods works and both method fails depending on the risk factor of the individual. So you want to monitor the response. The bottom line is, if you have an individual who has confirmed vitamin D deficiency and you have a blood level to follow, you start your regimen, you should follow the blood counts in 4 to 6 months to ensure that they are indeed improving. Vitamin D does follow dose-response relationship, as shown on this diagram. If you take more vitamin D, your vitamin D level climb higher. But the bottom line is it takes about 10 to 12 weeks to reach steady state. And that's why you do not want to recheck vitamin D concentration too early. If you check it in a month, it would not change significantly. So you want to wait for at least 3 months to recheck. And one thing I have to include for completeness is D2 versus D3. You're going to hear a whole lot about it. You probably have heard a whole lot about it. You're probably part of the debate with your colleagues whether D2 or D3 is better. Now, the background information, D3 is the endogenous vitamin D mammal synthesized. D2 comes from plants. So that's really the major difference. Now, is one better than the other? There is some scientific evidence suggesting that D3 works better for mammals, for humans, because that's the endogenous compound. So I don't want to dispel the scientific finding. Yes, based on high-level scientific analysis, D3 seems to be more potent than the plant-based D2. But, remember, dietary supplements are regulated under DSHEA. And nobody would prove that the label that says D3 actually is D3. And so, since we cannot confirm product purity and potency from the clinical standpoint, D2 and D3 doesn't make a difference. So again, from a scientific standpoint, there is reason to believe D3 seems to be better for humans. But until there are ways for us to confirm that a product that is labeled for D3 indeed contains D3 and the exact amount, for now, D2, D3 are probably interchangeable due to this limitation. And the reality is, whether you take D2 or D3, you have the same improvement in your vitamin D profile. Now, this is a very interesting study that was conducted to compare D2 versus D3 on vitamin D blood profile. You start with the control, which is the yellow bar, and you can see that if you don't take any vitamin D supplements, there's no change in the D2 level, and there's not much change in the D3 level either. So overall vitamin D level is not changed for the yellow bar. When you look at the purple bar, that's the D2 supplemented group. And the supplement is actually confirmed. They confirmed that it contains 2,000 units of D2 for the research. There is a very significant increase in blood D2 level. But what happened to D3? It goes down. So what happened is when you increase your D2 intake, you replace your endogenous D3 level. So you don't become vitamin D toxic. But when you look at your total vitamin D level, it's improved. When you look at the green bar, the subjects who take vitamin D3, there's no change in D2 level, no surprise. D3 level is substantially increased, which translates to the same magnitude of increase for D3, for vitamin D in the blood. So the take-home message is whether you take D2 or D3, when you check our vitamin D level, it will still be reflected. And our body auto-regulates the vitamin D2 and D3 ratio based on our intake. Here is a quick slide to summarize the sources of vitamin D from different kind of food and also vitamin D supplements. There is, you probably know, that a prescription strength vitamin D, which is 50,000 units. It is a D2, and this is covered by most insurance, and it costs you several, 50 cents to $1 for the entire treatment. One of the most established regimen is to give 50,000 units weekly for 8 to 12 weeks. So in a way, that's minimizing any kind of calculation. If you have vitamin D deficiency, you give 50,000 units once a week for 8 to 12 weeks. Or if you don't have access to prescription, or if you don't want to use a prescription, you can go back to what we said in the general rule or simple rule. Simply increase your dietary intake by supplements, by diet. Every 1,000 unit increase should bring up your vitamin D concentration by about 10 nanogram per milliliter in 3 to 4 months. How we prepare food actually affects vitamin D content. And I want to bring that up to you. If you eat raw salmon, the vitamin D content is about 207 units for every 3.5 ounces. So that's good. You go to a sushi bar and you eat raw salmon. There's good sources of vitamin D. Now, I don't know how many people actually just microwave salmon. That doesn't sound too good to me. But if you just microwave a big slab of salmon, the vitamin D content is essentially the same as raw salmon. When you bake it, you can see that the vitamin D content is reduced by about 10%. If you fry it, you just reduce the vitamin D content by 50%. So important message is the way you prepare the food can actually alter the amount of vitamin D in the food. To complete our discussion, I want to emphasize that vitamin D supplementation is probably helpful in our population, but not risk-free. Here's one classic study published in JAMA in 2010, suggesting that taking high-dose vitamin D supplementation actually increases the risk of falls and fracture. And you can see that under falls, for the first 3 months after taking a big dose of vitamin D, the fall risk go way up. Now, the dose matters. In this study, these individuals were asked to take 500,000 units once a year. 500,000 units once a year. The rationale behind it is, well, vitamin D has a pretty long half-life, and it is lipid soluble, so it probably would stay in the body for some time, and that may increase adherence. Take it once a year is way better than take it every day. And that's how these ideas of taking a big dose very infrequently has emerged. But it appears to translate to risk of falling. Now, when you look at the blood vitamin D level, it makes sense. Those who take the super high dose, 500,000 units once a year, the blood level within the first 3 months is way elevated, and then it declines down. And the fall risk is also the highest in the first 3 months, suggesting that high vitamin D level may actually worsen fall risk. The exact mechanism is not clear. There is some evidence suggesting that vitamin D at very high level actually cause neuromuscular weaknesses and block calcium homeostasis, which may result in increased fall risk. Now, this is very consistent in every single study with so-called mega doses of vitamin D. Here's a study summarizing all the published data, and you can see that in all these doses, you see higher mortality rates, higher fall risk, higher fracture risk. And what is common is vitamin D is given at 300,000 units once, 100,000 units every 4 months. So we're talking about 6-digit dosing. So the take-home message is do not give megadoses based on our existing evidence, which goes back to the Dutch sliding scale approach. They recommend not to give more than 25,000 units per dose. Now, there are exceptions. If you have a patient who has short bowel syndrome, who has severe malabsorption, you may have to give 6-digit doses to maximize absorption. So that's kind of an outlier. But for most individuals, we really do not want to use super high doses. So finally, what is the current recommendation? The U.S. Preventive Services Task Force actually published a paper earlier in 2014, and they come up with a lot of information suggesting that, well, based on all the published data, we don't recommend a routine monitoring of vitamin D. But based on what we've learned about bone health, based on what we understand about where we live in the Pacific Northwest, it is probably reasonable for us to really monitor vitamin D level on a regular basis, and certainly in at-risk patients. So we are talking about patients who have history of decreased oral intake. We are talking about patients who have history of osteoporosis. So for any at-risk patients, we should consider routine vitamin D monitoring. And I think many of the family practice providers come to the approach to just check vitamin D annually. I don't think that's a bad practice, in spite of the recommendation for not doing it on a regular basis. Deficiency can be treated by 50,000 units for 8 weeks. That's once a week, or simply increasing the daily maintenance, as I mentioned to you. And then again, avoid using doses higher than 100,000 units per time, because that seems to increase the risk for falls. So let's try to put things into perspective. Craig, 72-year-old man, and just visited his primary care provider for his annual checkup, and his vitamin D level is low and shown to be 14.4. And I've given you some other relevant history as well. He has hypertension, hyperlipidemia, and type 2 diabetes. So from the vitamin D management standpoint, 14.4 we can classify as deficiency regardless of the ethnicity at this point. How do we approach it? Well, based on what we have discussed, there are several ways to do that. You can use a prescription vitamin D, which is 50,000 units weekly for 8 to 12 weeks. And that's covered by most insurance, and the cost would be about $1 to $2. And then recheck the vitamin D level in 8 to 12 weeks. The other approach is to increase his daily vitamin D intake. You can advise him to take a vitamin D supplement. The question is how much to take. Now remember, every 1,000 unit is supposed to bring up the vitamin D level by 10 points. So if he takes 1,000 units daily, you expect 3 to 4 months later, his level will be about 24, 25. And if you're aiming for 25 or higher, he probably should take at least 1,500 units a day on top of his current diet. Make sense? Yeah. So that's another way to approach it. So you want to assess the patient's affordability, adherence. Clearly, taking 1,500 units daily of vitamin D, it's out of pocket, as opposed to a prescription, 50,000 units. So these are some factors to take into account. There are other dietary risk factors, as we discussed. This patient is lactose intolerant, so you expect him not to have high milk intake, which also brings down his dietary vitamin D. And so, supplement becomes a more important way to improve his status. Other things to look at include his current diet and drug. So that's a quick overview of vitamin D, which we spend the majority of our time because it is really a relevant topic in the elderly population, and especially in our region. I want to switch gear a little bit to cover 2 other topics. One is thiamine. Thiamine deficiency has been way underappreciated until the last 5 or 6 years with the reemergence or emergence of bariatric surgery. And we start to realize that, thiamine deficiency is actually way more common than we previously believed. Now, one reason is the thiamine pool in the body. We only keep about 25 to 30 milligrams in the body. And we would deplete it all in about 2 weeks. And that's why I mentioned to you earlier that in a patient who has insufficient oral intake for 2 weeks, chances of having thiamine deficiency is very high. We get thiamine from 2 ways, from diet and the microbes from the intestine. But we know that the colonic formation of thiamine is insufficient to maintain normal thiamine synthesis. So we really rely on adequate amount of food intake, and I've listed the food with rich sources of thiamine for your reference. You look at the symptoms, you know why I say dietary intake predicts the risk of thiamine deficiency. The most common symptoms associated with thiamine deficiency. Now, we are talking about the most severe type, Wernicke encephalopathy. So basically, you are completely disoriented. The most common symptom is actually vomiting. Probably, thiamine is not causing the vomiting, but instead, the uncontrolled vomiting limits how much food you can keep in the body, which results in thiamine deficiency over time because of depletion. Under that is the more common symptoms of thiamine deficiency, which is mostly neurological. Eye movement, ataxia, leg neuropathy. So you have somebody who comes to you saying, well, my leg kind of hurting. I don't know why. It's kind of numb. I have problem walking. You want to go back and look at the diet intake. That may explain some of the symptoms. Patients with diabetes. You may want to optimize a person's thiamine intake for patients with diabetes, and that can root out the neuropathy that is caused by thiamine deficiency, which is highly treatable versus diabetic neuropathy. And another thing I want to highlight is psychosis. There have been numerous case reports showing a psychotic presentation with severe thiamine deficiency, to a point that the patient was admitted to an ED, to a psych ward, not responding to antipsychotic drug, but then with several doses of thiamine, the patient go back to normal. So thiamine deficiency can present with various type of disorders, but most commonly affecting the neurological system. The slide here shows you that there is a clear dose-response relationship of thiamine supplement. So the more you take by mouth, the more you seem to be able to absorb, and that's good news. The downside is it takes a long time for you to replenish thiamine by mouth. And so the bottom line is, if you have a symptomatic patient, you want to use intravenous route. Shown you here is a table extracted from a very recent review article on thiamine deficiency. And it gives you all the established regimens in different disease states, symptoms, or population. And again, you see that the treatment dose usually start with about 100 milligrams of thiamine. And again, in patients with neurologic deficits, you should always start with intravenous therapy. Now, you can also give thiamine by IM injection. The downside is 100 milligrams of thiamine IM is a pretty big volume. So for somebody who is elderly, frail, that's probably not a good idea. So ideally, somebody who has neurologic deficit should probably be managed in the ED and the hospital. And by then, hopefully an IV access is established, and that's where you would start your thiamine treatment. For maintenance or prevention, it's probably okay to use oral. So here is a summary for thiamine in elderly. Risk factor for deficiency alcohol use, which we know. Again, focusing on oral intake. Depression, GI upsets, other dementia, anything that affects oral intake for at least a week, you may want to watch out for thiamine deficiency, and you may want to empirically supplement thiamine. Uncontrolled vomiting for more than 3 to 5 days definitely presents a very high risk for thiamine deficiency. IV versus PO, anyone who is symptomatic should get thiamine treatment intravenously. A little quick touch up on other common supplements. Iron. There are 2 types of iron. This is a pretty busy diagram. But basically to show you that the 2 common forms of iron, we have heme iron that comes from meat, but more commonly blood. And non-heme iron, which is iron supplement, iron sulfate, iron gluconate, for example. The absorption and the regulation of these 2 types of iron are governed by different mechanisms. And so, that explains why heme iron actually lead to different clinical response than iron sulfate tablets. So let's just kind of quickly go through the take-home message on iron. Duodenum is the primary site for non-heme iron absorption, versus heme iron can be absorbed anywhere in the GI tract. So what that means is if a person who has partial small bowel resection or gastric bypass, the ability to absorb non-heme iron goes down, but may be better maintained with non-heme iron. The other thing is iron absorption is saturable. So by increasing the dose, which most clinician tends to do, you have an iron deficiency anemia. After a round of treatment, the anemia is not resolved. So let's escalate the dose. Iron absorption may not increase proportionally, but instead you just introduce more side effects. So increasing the dose may not really be the right thing to do, but instead you want to extend the period of iron supplement. And generally speaking, non-heme iron, so we are talking about iron sulfate, had a bioavailability between 10 to 20%, versus heme iron actually can get absorbed better. But if you have documented iron deficiency, your GI tract can extract iron much more efficiently. So that's one of the mechanisms to increase iron absorption and preventing iron overdose. Here's a list of iron supplements commonly found in the United States. A different salt form provides you with different elemental iron. And as you see, iron fumarate provides you with about 33% of elemental iron, versus sulfates give you 30%, and then gluconate 12%. Now the bottom 3, carbonyl iron, polysaccharide complex, and heme polypeptide, are sort of newer formulations, supposedly incorporate iron polymer, heme iron, and they tend to cause less GI side effects. Now you may recall from patients or in the past learning that one of the most common side effects of iron supplement is upset stomach and nausea. The newer products, including the carbonyl polysaccharide complex and heme iron, claims to have lower side effects from some studies, but they have not been formally studied in a comparative trial. But that's something to keep in mind that you may want to use. Here's the most important take-home message. When you are treating iron deficiency, your goal is not just to increase hemoglobin, but increase iron store. Iron is stored in the form of ferritin. You will first deplete ferritin before you develop iron deficiency anemia. In order to treat iron deficiency anemia, you have to restore body iron storage. Otherwise, your body is going to be depleted with iron storage again, and then anemia would come right back. So it is important to monitor both hemoglobin concentration as well as ferritin. So generally speaking, it takes 2 or 3 additional months to fully restore ferritin concentration. Give you the rate of normal hemoglobin increase with typical iron supplements. But generally speaking, if you have documented iron deficiency anemia, the patient should be on iron supplement for at least 3 months or longer. And here is really the most important message I want to forward to you is that you see a lot of iron sulfate 325 3 times a day. It's not a good idea. Studies have shown that this regimen does not lead to better clinical outcomes, but much higher dropout rate or non-adherent rate and adverse side effects. So the most logical approach is to actually start with 325 once a day. And you may even start with products with lower elemental iron content, such as iron gluconate. Start with lower amount, just make sure that the patient is taking it. Then reassess in 3 months. In 3 months, you see no good response, you may want to increase the frequency or increase the dose by 1 more time a day, as long as the patient can tolerate it. Because the most common treatment failure for iron supplement therapy is GI intolerance and then non-adherence. So avoid using 325 TID, start with once a day, and just be patient. And for patients who have a hard time tolerating iron sulfate or iron gluconate, you may consider the polypeptide or heme iron products. The downside is they tend to be much more expensive. It may cost the patient $20 to $30 a month for that kind of products. So there's a downside of using those products, although claimed to be better tolerated by mouth. So bringing you back to this same patient, in addition to vitamin D deficiency, you look at the hemoglobin, 11.8, MCV of 73, and suggesting microcytic anemia. So the risk of iron deficiency is probably real. And again, how do you want to approach this patient? Again, go back to conduct a more thorough diet history. Non-meat eater are probably at higher risk for developing iron deficiency than meat eater. So you want to look at what kind of diet he is on. And if you want to consider iron supplementation, you want to talk to the patient to see what they can afford and start with the least aggressive regimen. So again, iron sulfate or iron gluconate once a day for at least 3 months and watch from there. Now this is particularly important for elderly patients because you all remember that iron can cause constipation, which is not something you want to worsen in an elderly person. And you give them iron sulfate 3 times a day, you're going to worsen a lot of the GI side effects. So again, start low, be patient, watch for side effects, and watch for adherence. That's really the goal. And what is the treatment goal? The treatment goal is, number 1, hemoglobin concentration be normal, but you don't stop there. You want to make sure that ferritin, which reflects iron storage in the body, is also normal. So that usually means continue iron supplementation for another 3 months or so after hemoglobin concentration is normalized. To wrap things up, I want to briefly touch base on omega-3 fatty acid. Oftentimes we just refer to it as fish oil. Now, the whole idea of looking at fish oil use and omega-3 fatty acids started based on the outcomes of the Nurse Health study back in the 90s. And it was shown that diet containing more fish intake is associated with lower risk for myocardial infarction and other cardiovascular complications. And now there are a number of disease states that people are interested in, especially in the geriatric population. Hypertriglyceridemia is the most established clinical benefit of fish oil. But there are people using it for atrial fibrillation, Alzheimer's disease prevention, and macular degeneration. We have a couple of colleagues recently asking me that they have been advised by their ophthalmologist to take fish oil. Does it have any basis for that? And I'll focus on these two in the next few minutes. Now, let's start with why omega-3 fatty acid is beneficial or potentially beneficial. When you look at fatty acids, there are two major groups of essential fatty acids, omega-3 and omega-6. They are both important precursors for prostaglandin synthesis. So we need these fatty acids in order for us to make prostaglandins and leukotrienes, which regulate vascular tone, regulate inflammatory response, and prevent infection. And we don't make omega-6 and omega-3, so they have to come from diet. What's interesting is omega-6, if you look to the lower right-hand corner, drives the formation of leukotriene A and C family, and C4 in particular. The leukotriene C4 family appears to have the most profound inflammatory response. When you look at omega-3, the downstream products are the 5 families, leukotriene C5 and leukotriene B5. The 5 family appears to have an anti-inflammatory response. So it appears that under normal physiology, we balance the 4 series and the 5 series of leukotriene production, and that's one way for us to down-regulate inflammation. If you shift towards the 4 series, you will develop some sort of chronic inflammatory response, which we try to confirm that and identify that a lot of disease states are associated with chronic inflammation. And so the hypothesis is if we introduce omega-3 fatty acid in a diet or substitute omega-6 and omega-3, we can reverse the inflammation. And when you look at omega-3 fatty acid, there are 3 main components. Now, omega-6, you see arachidonic acid in the middle. So there's no doubt omega-6 has a pro-inflammatory effect. For omega-3, there are 3 main active components, alpha-linolenic acid, or ALA, and then you have eicosapentaenoic acid, or EPA, and then DHA. And in terms of potency as an anti-inflammatory agent, DHA is the most potent compound, followed by EPA. ALA has very, very little anti-inflammatory response. Now that explains why you go to the grocery store, you look at food labels. Companies try to sell the product to you by saying this is rich in DHA. You can't sell anything if it is rich in ALA because the potency is weak and it has to be activated to DHA. So DHA is really what we look for in terms of high anti-inflammatory profile. The question is, how much DHA do you need to achieve anti-inflammatory response? So here is a cross-section study looking at about 4 grams of ALA alone, EPA alone, and DHA alone. And the surrogate marker is arachidonic acid. If they work as anti-inflammatory agents, you expect any of these long-chain omega-3 fatty acid would drive down arachidonic acid concentration. You see ALA supplementation at 3.7 grams, it just doesn't do anything. Nothing has changed. Versus when you look at the EPA supplementation, the 4 grams of EPA drives up blood EPA concentration very, very high. No effect on DHA, but it does reduce arachidonic acid concentration in the blood. And when you look at DHA supplementation, you achieve the same thing. What's interesting is you actually start getting some EPA as well. So the body tends to interconvert EPA and DHA. But ALA has very, very little effect. So what that means is, I'm going to skip this one. This one is probably a little too much. The bottom line is we want to take EPA and DHA, and ALA would have very little pharmacological benefits. Now here is a long list of food that give you high concentration of EPA and DHA for your reference. And what I would like to do is looking at the outcomes, looking at macular degenerations. And this is the question I get pretty frequently in the last couple of years. When you look at the existing studies, it appears that omega-3 fatty acid supplementations cannot prevent macular degeneration. When you look at the risk ratio, there's really not one study showing a significant reduction at all. And the question is why? We do know that DHA and EPA can enter the retina, and you can find in eye tissues. One reason is the dose. Going back to the previous slides, you see that we need about 4 grams to really suppress arachidonic acid concentrations. In many of these trials, the dose of DHA and or EPA is about 300 milligrams. So in most cases, the studies fail to show benefit because the dose or the amount used is not optimal for us to really look at clinical effect. Now, the next question is, if you take much bigger doses, would that translate to better clinical outcomes? And that's the question we have to answer in the future clinical trials. So the bottom line is, in most cases, these trials underutilize the amount of omega-3 fatty acid. And same thing is true for cognition and as an indicator for development of Alzheimer's disease. And you can see that when you give them EPA and DHA, their blood level goes up, but it doesn't translate to any clinical benefit regardless of the type of performance scores you use, ranging from mini-mental status studies to other memory recall. And again, the amount used may make a difference. As you may recall from the previous slides, only 600 milligrams. So to sum up, I think the data on omega-3 fatty acids, especially for macular degeneration and Alzheimer's prevention at this point, is inconclusive. And not really because omega-3 is ineffective. It's mostly because we are not giving the optimal amounts that we understand from science. And we don't have high quality clinical trials to prove that higher doses actually works and, more importantly, safe. So we do want to watch out for more clinical trials using much higher doses to answer that question. So this is second to the last slides to wrap up with the same case. And would this same patient be benefit from using omega-3 fatty acid supplements? The first indication is hypertriglyceridemia, and that's the most established indication. And you look at this patient's triglyceride is 132. So based on that, omega-3 fatty acid supplementation probably would not change the clinical outcome that much from the lipid management standpoint. Now, would that affect his risk in developing Alzheimer's disease or dementia? As I mentioned to you, the data at this point is inconclusive. Probably not. So if you look at this patient's risk factor and the laboratory results, there may not be any outstanding reasons for him to be on omega-3 fatty acid supplementation. This slide is just a quick summary of the micronutrients that I mentioned to you as a take-home table. And finally, I have Appendix 1 and 2 here. Herbal supplements always come up. I don't want to spend too much time to go through it, but I summarize the data for you in the literature, and they're specific for geriatric population. So that would be something take home for you to use just for completeness. And the time is 5:20, so I think I'll stop here, and I am happy to answer questions at this point.
When the questions come in on the, did John tell you I can read them off to you so you don't have to try to track them on there?
Okay.
We have questions from the audience here as the people out on the site start getting their questions ready.
Yes.
I have a question about things like essential oils and the fly supplementation with DHEA. When it comes to DHEA, it says for ingestion only. How do they work around that kind of regulation?
So the question is, how do fish oil and other products, how are they regulated, right?
Or like the essential oils or the fried patches that they have now?
The patches, the skin patch is not regulated under DHEA because remember, DHEA covers only oral products.
Yeah.
So the patches will have to go through product testing. Now, there are people who can bypass it. For example, they can manufacture from outside the country and then rebrand it. So we do have products like that. So you may want to look at the product you are using or your patient's using. And if it is an RX product, that suggests that it has undergone vigorous efficacy and safety testing and clinical trials versus anything that is labeled as supplement, they wouldn't, it hasn't been done.
So we have one that says a geriatric patient with tongue pain, B12 level is borderline. Is it okay to trial B12 over the counter?
Tongue pain is a very non-specific presentation. It is usually associated with some sort of B vitamin. Other B vitamins that can contribute to a tongue pain include thiamine, niacin, and pyridoxine, so B1, B2, B6. So what I would suggest is, again, go back and look at the patient's more comprehensive diet history. For B12 deficiency, usually there is a precipitating factor. Drugs such as omeprazole may decrease B12 level. In a patient with B12 deficiency, you may also see evidence of anemia. So that's what I would consider. With regard to empirical trial, probably there's no harm to do it, but I just don't like to, empirically start a bunch of vitamin without looking for other more specific causes. But the tongue pain, yes, you can follow the clue of vitamin B deficiency.
Do you recommend iron with vitamin C for better absorption?
Okay, the question on iron and vitamin C absorption, it's probably a myth. There are no strong data showing vitamin C improves the absorption of iron supplements. Now, vitamin C probably acts as an antioxidant in the gut. And the reason is in food, iron is present in the 3+ form, which has to be changed to 2+. And the presence of vitamin C would help convert that process. But iron supplement already exists in 2+ form, and there has not been strong data showing providing additional ascorbic acid actually enhance the absorption. And if anything, it may actually cause more GI irritation. So the bottom line is, it wouldn't hurt, but it may not help. But if you have a patient who has severe GI symptoms, I probably won't do it.
And then Anchorage, looking back at the Craig case study, why wouldn't the standard practice be to just write the prescription for 50,000 IUs of D, since we have no idea what D supplements really contain, since they're not regulated. The prescription route seems more cost effective for the patient anyway, since insurance covers it.
Yes, so 50,000 units weekly for 8 to 12 weeks is definitely an acceptable approach as well. So you can go either way. And I agree with you, for patients who have insurance coverage, this is a much cheaper approach.
And another vitamin D on page 12 states the recommendation is to take weekly dose of no more than 25,000, yet on page 14 it says 50,000 is best. Please clarify.
Okay, so the 24,000 dose comes from the Dutch trial, and their recommendation is based on their repletion experience. And the 50,000 unit weekly is based on a more conventional practice. And there has not been any data showing 50,000 weekly can cause significant harm. So 50,000 weekly is probably okay. And in fact, if you replace vitamin D with 50,000 weekly after 8 weeks or 12 weeks, and the improvement is insufficient, you probably would want to go to 50,000 units twice weekly instead of going up on a dose. So again, based on what I've shown you, very, very high doses intake, such as 100,000, 200,000, may increase the risk of fall. So you don't want to go that way. And so the better way to go is to use 50,000 unit once a week, twice a week, or 3 times a week to increase the frequency.
And then Elizabeth Phelan, who, by the way, is our esteemed director of the Northwest GWEC, mentions a study published in this week's JAMA Internal Medicine showed that high monthly dose of vitamin D had no benefit on lower extremity function and increased falls in older adults who had previously fallen.
Yeah, and that's very consistent with the meta-analysis that every single study tried mega doses. And when I say mega doses, we are usually referring to 6-digit, 100,000 per dose, and usually given, more than once a month. And the clinical outcomes usually doesn't look good.
And then my mom has renal failure, and 3 months ago her vitamin D level was 9. For the past 3 months she has been taking 2,500 a day, and now it is 30. Should she increase a bit more? Because of the renal failure, she doesn't absorb all of the vitamin D she takes.
The question of renal failure changes vitamin D regulation and dynamics, because you may recall that vitamin D last activation process in the kidney. So what I would suggest is to go back to the prescriber and look at her calcitriol levels. In a patient with kidney failure, that's when you want to look at calcitriol levels.
And then the billing VA says if you give vitamin D 50,000 weekly for 8 to 12 weeks, what do you do after the 12 weeks? Does the level stay up?
If you stop, the level goes back down. So remember, this regimen is for replacement. So basically the tank is empty. You use 50,000 units weekly for 12 weeks to fill the tank. But you have to increase the maintenance at the same time. So it is equally important to think of how you want to maintain optimal amount of vitamin D. And in most patients, you may want to sit down and look at the diet or initiate some sort of vitamin D daily supplements beyond the typical 600 units per day.
And I think the Whitefish Geriatric Center is maybe talking about the JAMA study was 25,000 IUs monthly. All levels above that were associated with falls. I don't know that study to...
I'll let him finish typing, but But yeah, there is a concern of using high doses of vitamin D, and I think we have established that. Now the question is, what is the upper limit? And the answer is, at this point, unclear. But given the long history of using 50,000 unit weekly, I think at this point we consider the 50,000 unit weekly an acceptable and safe regimen for replacement. But that's why when you look at the data, and if you don't feel comfortable with using 50,000 unit, you can certainly increase your daily maintenance. There's no reason not to do that.
And then Rob is asking about his mom with renal failure in regards to calcitriol. Could you say a little bit more about what calcitriol is and its relationship to calcium?
Oh, calcitriol is the 1,25-dihydroxy vitamin D, so that's not the calcium. That's the most active form of vitamin D. You may recall from that diagram, 25-hydroxy vitamin D has a half-life of 15 days, but calcitriol, 1,25-dihydroxy, has a half-life of only several hours. Under normal circumstance, we don't check that because we convert it back and forth right away. But in patients with renal failure, you can have 25-hydroxy vitamin D level very, very high. You just don't make enough calcitriol. And that's when you actually want to measure calcitriol levels.
And then Kalispell is talking about, let's see, same valley as whitefish. Our sunny days here average 75 per year historically. Patients' vitamin D levels have been in the basement, and their supplements are always at least doubled the average. So I guess they're supplementing more, much more than.
Yeah, and you know, concerning vitamin D, there is clearly a discrepancy between the Preventive Task Force recommendation with what we do. And I want to show you what the evidence is and what the current guideline is, because somebody is going to show you that paper. It is important to keep in mind that we live in a very different region than the rest of the country. You know, if we live in Texas or Florida, we don't have that concern as much. We live in a very different place. So I think what we really need is, for those of you who are providing much higher doses and publish the data, share with it so we have some sort of evidence to discuss it. We look at our bariatric surgery obese patients here in Seattle. We saw that at least 2,000 a day is really the optimal maintenance. But we are talking about a very defined population whose BMI is over 30.
The chat box got pretty active. Are there other questions here in the room?
Yeah.
I know you guys can affect things like magnesium, about vitamin D at all.
There is.
Can you repeat the question?
Oh, the question is whether proton pump inhibitors can affect vitamin D efficacy or absorption. There's no strong established evidence that proton pump inhibitor can negatively affect vitamin D absorption. We are more concerned about magnesium and vitamin B12. Sure.
These newer sources of iron that you talked about, are these vegan, or are they?
The question is, the newer iron supplements, the iron polypeptide and heme iron, are they vegan? The heme iron is not vegan for sure, because heme comes from animal. The polypeptide, I don't know. So what I would suggest is you can look at the product specifically. And most of the products are actually available in a couple of the online merchandise. And again, I don't have stock option in Amazon, but you can find most of them in Amazon. And the manufacturers also have a pretty detailed website as well. And just keep in mind that the newer products tend to be pricier. So, you know, affordability is an issue, especially when you are talking about months and months or years of supplementation. So adherence comes back to become a major issue in deciding your options.
Thanks, Dr. Chan, for a great presentation.
Thank you.